Thank you very much, Keith. Good morning again. So, I declare that I am a member of the Medical Advisory Board of Pulsion. So, you know the concept of fluid responsiveness. You know that when we pull all the studies previously published, for example, in this report with Frédéric Michard, we found that only 52% of patients respond to fluid in terms of increase in cardiac output or stroke volume. Only 52%. So how can we define fluid responsiveness? In general, we define as a significant increase in stroke volume or cardiac output in response to a fluid challenge. You remember the Frank-Starling curve with the ventricular preload on the x-axis and stroke volume on the y-axis. You know that preload responsiveness is defined on this T part of the curve, while absence of preload responsiveness on the flat part of the curve. And you know that volume infusion will increase stroke volume only if both ventricles have preload reserve, that is to say, are preload responsive. So, fluid responsiveness is equivalent to biventricular preload responsiveness. Now, we know that there is no single Frank-Starling curve, but a family of curves between a normal heart and a failing heart. And therefore, we know that a given value of any preload parameter cannot give you information on the presence or the absence of preload reserve. This is the reason why static measures of preload cannot reliably predict preload reserve and hence cannot reliably predict volume responsiveness. So this is the reason why dynamic indices of preload responsiveness have been proposed. And the first concept is the respiratory variability of stroke volume or its surrogates. So just very briefly, I would like to remind you the effects of mechanical ventilation on the cardiovascular system. You know that mechanical insufflation is able to decrease right ventricular filling, and this will decrease right ventricular stroke volume at inspiration, but of course, if the right ventricle has some preload reserve. This decrease in right ventricular output during inspiration will result in a decrease in left ventricular filling. But this will happen after 2 or 3 or 4 heartbeats later because of the long pulmonary transit time. And so this will happen at expiration in general. And the decrease in left ventricular filling will result in a decrease in left ventricular stroke volume at expiration, of course, if the left ventricle has also some preload reserve. Therefore, schematically, mechanical insufflation will result in a decrease in left ventricular output only if both ventricles have some preload reserve. So, we saw just before that fluid responsiveness occurs only in patients with biventricular preload reserve. We just saw now that mechanical ventilation is able to induce cyclic changes in stroke volume only in patients with biventricular preload reserve. So if we put together these two statements, we can deduce another one, which is fluid responsiveness should correlate with the magnitude of the cyclic changes in stroke volume induced by mechanical ventilation. And this is a concept. This is the hypothesis of the concept of pulse pressure and stroke volume variation. So now, at the bedside, how to assess the respiratory changes in stroke volume. The first possibility is to use an arterial catheter and to look at the respiratory changes in arterial pressure. For example, for measuring pulse pressure variation. Why pulse pressure variation? Because pulse pressure is directly proportional to stroke volume. and inversely related to arterial compliance. So if we assume that arterial compliance doesn't change during the respiratory cycle, we can assume that the respiratory changes in arterial pulse pressure should reflect the respiratory changes in left ventricular stroke volume. This was nicely illustrated by the study by Kubitz and the group of Alvin Goetz and Daniel Reuter. They measured separately stroke volume variation using a flow probe in animals and pulse pressure variation using an arterial catheter. And they found a very nice correlation between these two parameters, either in baseline conditions or in case of decreased arterial pressure as well as increased arterial pressure. So a nice correlation, and this would mean that pulse pressure variation represents stroke volume variation. Therefore, we can postulate that pulse pressure variation predicts fluid responsiveness. This is a nice slide given by Xavier Monet. This represents the respiratory cycle and the change, the cycle change in preload. And in case of unresponsiveness, there is no change in pulse pressure variation, no increased pulse pressure variation. But in case of preload responsiveness, we may expect great changes, great arterial pressure variation. So the next question is how to quantify pulse pressure variation at the bedside. In this first study by Frédéric Michard and the group of Bisset, we proposed to measure PPV, pulse pressure variation, as a difference between the maximal value of pulse pressure and the minimal value of pulse pressure, and divided by the mean of the two values. And we can express that in percentage. And using this index, in another paper, we found that pulse pressure variation before fluid administration was higher in patients who will respond to fluid in comparison with patients who will not. And we found a 13% for the threshold value. And when we constructed ROC curves, taking into account sensitivity and specificity, we found that pulse pressure variation was far better than right atrial pressure and wedge pressure, which are static measures of preload, in terms of prediction of fluid responsiveness. This is a typical tracing of a patient with a high PPV, 32% before receiving fluid, and only 5% after fluid challenge. This means that pulse pressure variation is able to predict fluid responsiveness, but it can also assess the real changes in cardiac output, so it is easy to follow. So, since the publication of this pilot study and until the publication of this last paper by the group of Benoît Vallée, a lot of publications have been made, and all these papers found quite the same results, with the threshold values between 10 and 17%. We can also use stroke volume variation using arterial pressure waveform analysis. You know that some devices nowadays are able to provide stroke volume from arterial pressure waveform. And for example, for the PICO device, it is possible to analyze stroke volume variation by using the area under this historic part of the arterial curve. And using this system, the group of Perel demonstrated that in patients undergoing brain surgery, that the SVV stroke volume variation using this device was able to predict fluid responsiveness in these patients far better than CVP, again. And a 10% value was found as a threshold value. The group of Reuter and Alvin Goods also demonstrated the same result and showed that SVV was proportional to cardiac output after fluid infusion. Also, the group of Hofer, using the PICO device, found same prediction with SVV and PPV, and better than the prediction by static measures of preload like left ventricular endostic area, CVP, POP, and global and diastolic volume. And the cutoff values were around 13%. So now we have many studies using the PICO system demonstrating same results, good results in terms of prediction of fluid responsiveness by using stroke volume variation. Some other devices can provide similar results. For example, the study by Bias and co-workers demonstrating that SVV using the flow track system was able to predict fluid responsiveness by a similar way than pulse pressure variation. It was better than CVP and PAOP, and threshold value of 10% was found. Also, the paper by Canesson and co-workers demonstrating exactly the same results, with cutoff values of 10%. And there are also two other publications recently published demonstrating the same results. But there is also another publication by Deval and co-workers showing that this system failed to predict fluid responsiveness, at least in coronary artery bypass graft patients. So now we have to look at the comparison between all these parameters. For example, the meta-analysis by Marek and co-workers, they pulled a lot of studies addressing the issue of pulse pressure variation, stroke volume variation, etc. And they found that the base parameters were PPV, pulse pressure variation, and SVV in terms of a ROC curve. The area under the ROC curve was very good for PPV, a little bit less good for SVV. In terms of diagnostic odds ratio, very good for PPV. And when we compare correlation and area under the curve of PPV, SVV, and SPV, which is systolic pressure variation, it was far better than correlation and area under the curve of static parameters. We can also assess stroke volume variation using respiratory changes in aortic blood velocity using conventional echocardiography. For example, this study by Fessel and co-workers, we propose to use the delta V peak, which is a peak of velocity of the aortic Doppler measured at the level of the aortic annulus. And we found a good prediction with this index. We can also use esophageal Doppler monitoring device. And with Xavier Monet, we propose to measure aortic blood flow variation using another device than you use, the Hemosonic device. And we also found that responders to fluid had a higher aortic blood flow variation than patients who will not respond to fluid. We can also use maybe change in pulse oximetry wave. This is a paper by Natalini and co-workers, an Italian group, demonstrating that the arterial signal variation was similar to the plethysmographic signal variation, and they found cutoff values of 15%. Also, a study we did with Mark Fessel, we found same results. But there are some limitations of using heart-lung interaction indices. The first one is that fluid responsiveness is a physiological phenomenon related to a normal preload reserve. Therefore, detecting fluid responsiveness must not lead to infuse fluid systematically. And the decision of fluid infusion must be based on the presence of criteria of peripheral hypoperfusion. It is very important to remember that. Second limitation is that it's impossible to use all these indices in patients with spontaneous breathing activity. For example, in this study with Xavier Monet, we compare PPV into different populations. Patients who were fully adapted to their ventilator And we found a very good prediction with PPV and a threshold value of 12%. And patients who were mechanically ventilated, but they have some spontaneous breathing activity. And in this case, there is no prediction of fluid responsiveness by using PPV. Also, it is impossible to interpret these indices in patients with arrhythmias, which is obvious, but we have to remind. It is difficult to interpret these indices in a case of low tidal volume ventilation. Remember the paper by Daniel de Backer comparing the threshold value of PPV in patients ventilated with normal tidal volume and patients ventilated with low tidal volume. They found a very good prediction of volume responsiveness by using PPV, and a threshold value of 13% was found. But using low tidal volume, they found a lesser prediction with a lesser area under the curve and a lesser value of, for the threshold value. And also, it is impossible to interpret these indices under open chest conditions. It is obvious. And so, in these cases, we need some other indices. For example, passive leg raising. You know this maneuver. It consists of measuring the hemodynamic effect of leg elevation up to 45 degrees by starting from a semi-recumbent position. And this will produce a venous blood shift from the peripheral compartment to the central compartment. And the effects are reversible and transient. So we have to measure the hemodynamic response to PLR, passive leg raising, and we can postulate that this hemodynamic response to PLR should predict the hemodynamic response to volume infusion. And for that, we need a real-time hemodynamic monitoring device to track the transient changes in cardiac output. And many studies now demonstrated that PLR can provide a good prediction of fluid responsiveness by using many, many devices. We can also, and I finish on that, use another test in difficult cases, which is the end expiratory occlusion test. What is the hypothesis? During mechanical ventilation, inspiration cyclically decreases the cardiac preload. So, an end expiratory occlusion may prevent the cyclic impediment in cardiac preload and may act as a fluid challenge. And therefore, fluid responders should be identified by an increase in their cardiac output or surrogates during the end expiration occlusion test. And we found with Xavier Monet and using a PICO device, we found that patients who increased their cardiac output during this short maneuver, only 10 to 15 seconds, were patients who will respond to fluid or subsequent fluid infusion. And patients who did not increase their cardiac output during this maneuver will not respond to fluid. So my conclusion is that we can use clinically dynamic responsive indices, but in fact we have to identify two opposite situations in the ICU. Very schematically, early sepsis, the surviving sepsis campaign recommends to infuse fluid until CVP reached a level of 8 to 12, or maybe even 12 to 15 in patients receiving mechanical ventilation. We can agree or not with this proposition, but what I recommend is to add a test during this strategy, and a test capable of reliably detecting volume unresponsiveness at any moment of fluid resuscitation would help to better assess the benefit-risk ratio of continuing such a strategy. And there is another opposite situation, which is lung injury after the early stage has passed, because you know that a conservative fluid strategy is recommended now. And a test capable of reliably detecting when the degree of volume responsiveness at any moment of fluid restriction is too high would help to assess the benefit-risk ratio of continuing such a strategy. And fortunately, the test developed to detect volume responsiveness can also serve to detect volume unresponsiveness. And this This is why I think that we can use all these tests, at least in these two different situations. Thank you very much.